So coming to the most important part of today's class is on brachial plexus. So brachial plexus, in today's session we will know about its introduction, how it is formed, parts of brachial plexus, relations of brachial plexus, branches and applied aspect of brachial plexus. So the plexus means the bundle of nerves which form, means which join and divide. So something which joins and divides forming some meshwork is called as plexus. So brachium means the upper limb. So the nerve plexus supplying the upper limb called as brachial plexus. So let's see its formation. The spinal segments of C5, C6, C7, C8, T1 gives rise to brachial plexus, and that is, to be specific, anterior primary rami of C5 to T1. So if you see the spinal nerves divides into anterior primary rami and posterior primary rami, each spinal nerve. So anterior or ventral primary rami forms the brachial plexus and consists of roots, trunks, divisions and cords, and finally the cords will divide into branches. So the roots are always C5 to T1. Sometimes C4 may give contributes in the brachial plexus. If C4 contribution is majorly present, then it is called prefixed plexus. And in some context, we may have T2 contribution in the brachial plexus. In such cases, C4 won't contribute and there may be less contribution from C5. So in such context, it is called as post-fixed plexus. Prefixed if C4 contributes, post-fixed if T2 contributes. So we can divide the brachial plexus based on the relationship with the clavicle as the supraclavicular part, infraclavicular part and retroclavicular part. Supraclavicular part of brachial plexus are located in the posterior triangle of the neck. Retroclavicular, as the name suggests, retro means behind, so behind the clavicle. Infraclavicular part is just below the clavicle, that is in the axilla. And I just said now prefixed if C4 has larger contribution in the brachial plexus and T2 is completely absent. Postfixed if T2 always present and T1 is large and C5 is reduced. So the roots will join to form the trunks. So there are three trunks: upper trunk, middle trunk and lower trunk. So the upper trunk is formed by C5, C6. They join to form the upper trunk. C7 continues to form the middle trunk and C8 and T1 joins to form the lower trunk. And each trunk divides into divisions. So there are two divisions from each trunk. So one is the dorsal division, the other is the ventral division. So this is the ventral or the anterior division, light yellow, and dark one is the posterior or dorsal division. This is ventral, dorsal. This is ventral, and the darker one is the dorsal or the posterior division. So we can see here each trunk gives rise to ventral and dorsal, we know now, and these divisions joins to form the cords of brachial plexus. So there are three cords: lateral cord, posterior cord and medial cord. So here is the lateral cord. So the ventral division of the upper trunk, ventral division of the middle trunk joins to form the lateral cord of brachial plexus, and ventral division of the lower trunk continues as the medial cord of brachial plexus, and all the posterior divisions, which are otherwise called all the dorsal divisions, will join to form posterior cord of brachial plexus. So we can see all dark ones, they are joining to form the posterior cord of brachial plexus. So lateral cord, union of ventral of upper and middle trunks. Medial cord, ventral division of the lower trunk continues as the medial cord. Posterior cord, all the dorsal divisions of all three trunks joins to form the posterior cord. So that was about the roots, trunk, division, cords. Next we move on to the branches. So branches from the roots directly, there are some branches which form a nerve called as long thoracic nerve, otherwise called as nerve of Bell, which supplies serratus anterior muscle. So we can see C5, C6, C7, all are giving of nerve twigs will join to form this long thoracic nerve. And C5 also give rise to dorsal scapular nerve, which supplies rhomboids muscle, dorsal scapular. And C5 also contributes in the formation of phrenic nerve which supplies the diaphragm. And C5 rootlets also supplies longus colli muscles as well. And branches from the trunks, so that was about the roots. Next about the trunks. So the trunks, upper trunk, middle and the lower. So only the upper trunk gives rise to branches. So there are no branches from the middle and the lower trunks. So upper trunk, we can see a branch going upwards called as suprascapular nerve, which supplies supraspinatus and infraspinatus muscle, and nerve to subclavius, which supply the subclavius muscle. And further, this upper trunk is dividing into divisions, we can see. And now finally we are going to see the branches of each cord. So that was a basic idea. Branches we will deal little later. Coming to the relations, the roots are present in the posterior triangle of the neck. So the roots emerge out between the scalenus anterior and medius muscle. The trunks are related to the subclavian artery and vein and first rib. And divisions, they pass through the cervicoaxillary canal. They are the retroclavicular part. Divisions forms the retroclavicular part of brachial plexus, which pass through the apex of the axilla to enter the axilla. So apex is otherwise called as cervicoaxillary canal. And cords, we know medial cord, lateral cord and posterior cords are present. They are related to first and second part of axillary artery. They are named based on their relationship with the second part of axillary artery. So if you see the second part of axillary artery, medial cord is on the medial side, lateral cord is on the lateral side, and posterior cord is on the posterior side of second part of axillary artery. So based on the relationship with the second part of axillary artery, they are named. And branches are related to the third part of axillary artery. Cords are enclosed in the axillary artery in the axillary sheath. So that was the relationship. We can see the pectoralis minor muscle dividing the axillary artery into three parts, first, second, third part. So the cords are named based on the relationship with the second part of axillary artery. So roots, just now I told about the long thoracic nerve, which is arising from C5, C6, C7, which is otherwise called nerve of Bell or nerve to serratus anterior. Dorsal scapular, C5 directly. Phrenic nerve, C5 contributes in phrenic nerve, which I explained just before. Branches to longus colli and scaly muscles are also given off from C5, C6, C7 and C8. Branches only upper trunk gives rise to branches, suprascapular and nerve to subclavius. And we know the upper trunk is formed by the roots of C5 and C6. So the root value is C5, C6. Erb's point is very important because the upper trunk is otherwise called as Erb's point. It is the point where the six nerves meet. We'll see what are these six nerves. We know C5, C6 roots join to form upper trunk, which forms A and B. And the trunk divides into divisions, anterior and posterior. And trunk also gives rise to two branches, suprascapular and nerve to subclavius. So this point is the Erb's point where we can see the six branches are meeting here. So finally branches from the cords. Lateral cord, we can say LML, lateral pectoral, musculocutaneous and lateral root of median. So the lateral pectoral is this one. This thin branch is the lateral pectoral which supplies pectoral muscles, and musculocutaneous. This is the musculocutaneous, which is the continuation of lateral cord of brachial plexus. Lateral root, we can see here the lateral root here, which joins with the medial root. This one is the medial root to form the median nerve. So median nerve is formed by the lateral root and median root joins to form the median nerve. So these are the three branches. Medial cord, you can remember M, 4U, 4 M's and 1 U. 4 M's are medial pectoral nerve. So this is the medial pectoral nerve, which is giving rise to a communication branch. Then medial cutaneous nerve of arm. So this is the medial cutaneous nerve of arm, medial cutaneous nerve of forearm. Then medial root of median. This is the medial root of median, which I have already said. Then ulnar nerve. This is the ulnar nerve. So these are the branches of medial cord of brachial plexus. Posterior cord is the thickest cord of brachial plexus. This is the posterior cord of brachial plexus. This one is the posterior cord. Posterior cord, the thicker one, continues as the radial nerve. Radial nerve is the thickest branch of brachial plexus. So this is the radial nerve. So let's see the other branches. You can remember abbreviation as ulnar. Otherwise, you can remember STAR, S-T-A-R. S for subscapular. There are two subscapular, upper subscapular and lower subscapular. And T for thoracodorsal nerve or nerve to latissimus dorsi. Then axillary nerve and radial nerve. So these are the branches from the posterior cord. So this is upper subscapular, lower subscapular, then nerve to latissimus dorsi, then axillary nerve. This is the axillary nerve, and this is the radial nerve. So that was about the anatomy of brachial plexus. Clinical importance of brachial plexus. It is very important in brachial block where they give anesthesia, local anesthesia. Then cervical rib syndrome, compression of brachial plexus because of an extra rib, and the scalene anterior syndrome because of abnormal attachment of scalenus anterior muscle. And we have discussed about Erb's point. So Erb's palsy we are going to see, Klumpke's palsy and winging of scapula. Cervical rib syndrome and scalene anterior syndrome both can be considered together as thoracic outlet syndrome. Brachial plexus block, as I said, it is a regional anesthesia where the techniques and alternative to the general anesthesia, and it is given for the surgeries of shoulder, arm, forearm and wrist and hand. So we can see here the block. This is interscalene block, supraclavicular block, infraclavicular block, axillary block. So these are the sites where you can block the brachial plexus. Next, about the cervical rib syndrome. This is an extra rib. You can see here the 7 cervical transverse process of the 7 cervical vertebra continues as a prolongation which appears to be like an extra rib, this one. So this extra rib, it compresses the brachial plexus which are exiting out into the axilla. So accessory rib which arises from the 7 cervical vertebra above the first thoracic rib or cervical rib. Cause of compression of lower trunk of brachial plexus and subclavian artery. So not only brachial plexus, you can see the subclavian artery also may get compressed. Compression of brachial plexus is identified by weakness of the muscles in the hand, especially the base of the thumb and all, and tingling numbness sensations. And compression of subclavian artery, it is identified by Adson's test. Adson's test means the patient is asked to raise their hand and brachial pulse is felt in raising hand position. So the where the radial pulse in the arm is lost during abduction and external rotation of the shoulder and in raise of hand. Next, about the scalene anterior syndrome, which is also a part of thoracic outlet syndrome. So hypertrophy or abnormal position of insertion of scalenus anterior causes the compression. You can see here, this is scalenus anterior muscle, this is scalenus anterior muscle, and this is scalenus medius muscle. So the artery here is the axillary artery, along with that brachial plexus also would be there. So characterized by pain, tingling sensation in the forearm and hand. Next about the Erb's palsy. The site of injury is the Erb's point, that is the upper trunk of brachial plexus is called as the Erb's point, and cause is undue separation of the head from the shoulder. So it can be because of birth injury or fall from a height, or it can be sometimes during anesthesia. So birth injury, a abnormal undue stretch due to the drag of the head, during dragging of the head, it may cause undue stretch here in the upper trunk of brachial plexus. This is birth delivery, and fall from a height over the shoulder causing undue stretch here. You can see here, this is the undue stretch causing the damage to upper trunk of brachial plexus. So the nerves are mainly involved are C5, C6 because upper trunk is formed by C5, C6. The muscles paralyzed are biceps, deltoid, brachialis, brachioradialis, supraspinatus, infraspinatus, supinator. So all these paralysis may cause a deformity here, so which is called as policeman's tip hand or waiter's tip hand or porter's hand. It is a hand deformity which is like this. It is adducted, medially rotated and extended, and forearm is extended and pronated. Biceps and supinator jerks are lost in Erb's paralysis. Loss of sensation, deltoid. You can see here the deformity. The hand is extending posteriorly like this, as if he is holding a gun. So it is called policeman's tip hand. The next is the damage to lower trunk of brachial plexus is called as Klumpke's paralysis, where C8T1 is involved, the root values. So site of injury is the lower trunk of brachial plexus, cause undue abduction of arm. It can also occur during birth injury, pulling out the baby by holding the hand, or fall from a height. So while falling from a height, a person clutches something, causing undue suppression in the lower trunk. So here is the lower trunk of brachial plexus. So this is the birth injury. So Klumpke's paralysis, mainly ulnar nerve is involved. So you can see a kind of claw hand, partial claw hand, and here we can see ptosis and some kind of Horner syndrome, because the sympathetic nerves are also present in the brachial plexus. So because of involvement of sympathetic nerves, the baby may have Horner syndrome. So the nerve roots are C8T1, muscles paralyzed, intrinsic muscles of hand, because ulnar nerve mainly supplies intrinsic muscles of hand. Ulnar flexors of wrist and fingers are paralyzed. Deformity is claw hand, unopposed action of long flexors and extensors. So there will be hyperextension of the metacarpophalangeal joint and flexion of interphalangeal joint. Okay, this one is the uh, claw hand. And cutaneous anesthesia and analgesia will be there on the ulnar border of the hand. Horner syndrome, I said, because of involvement of sympathetic nerves, cervical sympathetics. So ptosis, drooping of the upper eyelid, meiosis, anhidrosis, enophthalmos, loss of ciliospinal reflexes. So these are the symptoms which you see in the Horner syndrome. Winging of scapula, the medial border of the scapula becomes prominent when you ask a person to push against the wall. So that is because of paralysis of serratus anterior muscle. You can see the medial border becomes more prominent there. So sudden pressure on the shoulder or carrying heavy loads on the shoulder causes the winging of scapula because of damage to long thoracic nerve. And excessive prominence of the medial border and the inferior of scapula, and the disability is loss of pushing and punching movements because the serratus anterior is the boxer's muscle, and the loss of overhead abduction that is beyond 90 degrees. So that was about the clinical aspects of brachial plexus. Moving on to some questions here. So can you identify what is the structure? Okay, so Just an explanation, this is an axillary artery, this is axillary vein. And what is this nerve? So it is related on the lateral side, so it is the lateral cord of brachial plexus. And this is the medial cord of brachial plexus. Can you guess this one? What is this nerve? This is the median nerve. We can see, how can we tell? This is the lateral root. This is the medial root joining to form the medial nerve. This is the lateral cord of brachial plexus. This is the medial cord of brachial plexus. And here we can see the posterior cord continuing as the radial nerve as well. So, which among the following is the branch from the trunk of brachial plexus? Can you guess the answer? Suprascapular nerve and nerve to subclavius are from the trunk of brachial plexus. So the answers are A and D are the answers. Which of the following nerves carries the fibers from all the roots of brachial plexus? So all the roots from C5 to T1, which one will have? The median nerve will have, because it is formed by lateral and medial root. So the median nerve is contributed by C5 to T1, and also the radial nerve. Here the radial nerve option is not there, so C is the answer. So that is how we completed the brachial plexus with some questions. Thank you.